Okay, so here we are talking about physical and mental health. I do have some disclosures. So I've had some historical research funding from Gilead Sciences and ViiV Healthcare. Those are now completed studies, but that is that. So we're going to talk about, or hopefully achieve, 3 objectives today. Describe the intersection of aging, mental health, and medical comorbidities. Provide a whole person care framework for older people with HIV that integrates mental health as well as other comorbidities. And hopefully provide you all with some tools and approaches that are really easy to integrate into clinical care. And yes, I am a physician, but I think a lot of these tools can be really used by anybody. So don't feel shy about putting this into practice once you've left us today. So there's lots of reasons why we see an accelerated and accentuated pattern of aging in people living with HIV. I am not talking about all this today, so don't worry about that. But we are going to focus on stress, trauma, and depression, and how those sorts of things impact the aging process of people with HIV. So thankfully today, if you are diagnosed in your 20s today, you are expected to have a near normal lifespan. And I really like this study because it nicely shows in the green triangles and circles that over the years, we are closing the lifespan gap between people living with and without HIV, which is just really incredible, that we've gotten there. And I'm hoping at some point we actually completely close it. But in the orange circles and triangles, we're not really doing a great job at closing the comorbidity gap. So many of you may already know, but people with HIV tend to present with these age-associated comorbidities like heart disease and liver disease about a decade earlier than people who do not have HIV. And despite all of the advances that we had in the care of HIV, we really haven't been able to make a dent in it. So that's something that I think we still need to be working on and trying to have a better understanding of why does that happen. And some of you might think, well, why does that matter? Why does comorbidity matter if people are living to be almost as the same lifespan as anyone else? Well, comorbidity matters because it contributes a lot to quality of life. So people with multiple comorbidities, diabetes, blood pressure, et cetera, experience a poorer quality of life in general. And comorbidities are also associated with what we call the geriatric syndromes. So neurocognitive impairment is associated with comorbidities. And I put this little graph up here to kind of demonstrate a study that was done that showed that certain types of medical conditions like liver disease, heart failure, increase the risk of someone progressing in neurocognitive disease over a 12-year span. Age is there too, and age seems to have the biggest effect over these comorbidities that we see. But when you integrate it all together, so this Charlson Comorbidity Index score integrates several other comorbidities as well as age, we see a pretty significant difference. So having multiple comorbidities and being of an older age will increase your risk of having a progression to neurocognitive impairment. Frailty is another geriatric syndrome, and I'll speak about that in a little bit as well, that is associated with comorbidities. Impaired physical function kind of goes along with frailty, and polypharmacy, and we have a whole bunch of slide sets on that too. And so where does depression come into this? We talked about the comorbidities on the other page did not include depression. It was more of these medical comorbidities. Well, depression is kind of at the intersection of everything. In this first graph, it really demonstrates the prevalence and the co-prevalence of 3 conditions: depression, 45% of this cohort, so 65 that was mentioned earlier. This is a cohort that had a little bit lower percentage. About 40% of the people in this cohort had greater than 2 medical comorbidities, and 30% were currently using drugs or alcohol. So there's this intersection of mental health with substance use and comorbidities. And we see on the other graph, which is a whole separate paper, that they all interact to produce a situation where people are experiencing a lower quality of life. So these things are all important. And I don't know if any of you have taken care of a client and seen a medication list that's like this long and like a problem list that is this long. As you have seen, it's complicated sometimes to take care of some of our older adults because there is so much going on. And even, like as a provider, I'm lucky that I get 30 minutes. As an HIV provider, we get a little bit more time with our patients than people who are not. But I still can't get through that list. And it's often really difficult, and I have to bring people back time and time again. So when the 5 M's, Vince mentioned that earlier. We talked about the 4 A's. Vince mentioned the 4 5 M's, and now we're going to talk about the 4 5 M's here. So everybody has an idea of what that means. This is a geriatric approach, or this is basically what geriatricians have put together to tell people this is what geriatricians do. Because a lot of folks are like, oh, what does a geriatrician do? They just take care of older adults. But it's a lot more than that. I'm hoping to give you all a glimpse into the process of the geriatrician. And hopefully you can take some of this and also integrate it into your own clinical care practices. So we are going to start with the mind. And Dr. Ercole is going to be following me, so I'm kind of going to slip through a lot of these slides because she's going to go into much more detail. But the mind doesn't just mean dementia. So there's a lot of things that can alter cognition, like substance use, depression, delirium. So really thinking about this whole perspective of what are the things that are affecting cognition in our patients and our clients. And one thing that I have introduced into my practice is a routine practice of measuring cognition using the Montreal Cognitive Assessment Test. This test I like because, number one, they give you free access to training so that you can really understand what you're measuring and what these different things mean. And then you can use the test for free. So it doesn't hide behind a paywall like some of the other cognitive assessments do, and explores all of these different levels of cognitive functioning, from memory all the way through to executive function. And sometimes, most of the time I do this in the context of a Medicare annual wellness visit because it's really easy to say, hey, part of this visit is we do a cognitive assessment. It's a little bit more difficult to do that when your patient has seen you and they're in their 50s and you say, hey, I want to do a cognitive assessment on you. That's not often well received. But at least in the context of like Medicare annual wellness, people are like, oh, okay, like that seems reasonable. One of the things that it's used for most frequently is to measure people's cognitions over time. So you do it annually to see, are people stable in their cognition? Is things getting a little bit worse? Quick tip, oftentimes folks are super nervous about this the first time they do it, so it's not uncommon for people to actually do better a year later because they're like, oh my God, I got to answer this. I can't get it wrong because they're nervous and nobody really wants to be diagnosed or have any evidence of some cognitive decline. But I use it also if I pick up on something within the instrument. So say someone really seems to be struggling with their memory. That's an opportunity for me to be like, hey, I noticed that maybe you're struggling a little bit with your memory. What do you think's going on there? And sometimes people will say, oh, I'm just not sleeping well. And then they'll say, yeah, I've been really sad. I've been kind of lonely. Maybe I'm struggling with a little bit of depression. So it kind of opens the door to really explore, is this a symptom of something else? And then we talk about, do you think some of this memory issues is contributing to you not being able to take your medicines 100% of the time? And they're like, yeah, maybe that's what's happening. But it opens a really nice back and forth where we are kind of co-developing and even co-diagnosing what's going on. And kind of it enables us to make plans together to move forward so that they can continue to be healthy. And there are lots of things that we can do. And the reason why I think it's important to start talking about cognition early is that there's things that we can do to prevent it, believe it or not, prevent the decline of cognition. I think one thing that I've already explored is that there are a lot of these mediators or moderators of neurocognitive function. So we already talked about depression. That's a big one that can really impact how people are functioning from a neurocognitive standpoint. But loneliness is another one. So, sometimes I'll explore that with my patients, and I think like many of you probably experience, a lot of our older adults are very isolated and are really struggling, and they're not talking to anybody. And if you're not talking to anybody and all you do is kind of like passively, taking in YouTube and other things, then you're not challenging your brain. You're not, working your brain, and your brain is like a muscle, and if you're not working it and challenging it, then it will not continue to grow, or it will not be maintained. And then substance use is another one that can significantly impair cognition, as I'm sure all of us have also experienced. So other things that we can do is besides, trying to figure out are there other things that are contributing to some of this cognitive issues, is encourage our participants to, or encourage our patients and our clients to really maintain their mental activity. When you can, try to deprescribe any medications that are brain acting, like diphenhydramine, Benadryl seems to be such a commonly prescribed drug to our folks, and yet it's probably doing them more harm, particularly as they're getting older. And really address conditions that increase their risk for cognition. And this is actually the CDC's Alzheimer's disease risk chart. Exercise, if you're not getting enough exercise, that increases your risk. If you're smoking, if you're using excessive alcohol, obesity is on there as well, blood pressure, diabetes, depression, and hearing loss. So these are all modifiable things that our patients and clients can do and that we can help them with that could prevent them from developing cognitive decline moving forward. Okay, so we're going to get to the second M. Second M is mobility, which is also known as physical function. And the goal of focusing on mobility is we want to be able to encourage our patients and clients to have as much independence as they can for as long as they want. So if they are going to be able to kind of get to their appointments, do the things that they want to do, we have to make sure that they can walk and that they're mobile. So that's a big one, is keeping mobility at the front so that they can be independent. The other thing is we don't want them to fall, so we want to be able to prevent some serious falls. And there are many different things that we can do in that context. You can order or ask an occupational therapist to go visit the home and do a home safety evaluation. They look and make sure that the rugs are all pinned down. They make sure there's a grab bar in the bathroom. They look to see if there's rails on all of the stairs and that there's lighting that's appropriate so people are not going to be falling. And that's almost always covered, at least in California, to get something like that done. Balance training can also happen if you're worried about someone who's at risk of falling. There's lots of other exercise programs. Just a reminder that in HIV, we start bone density screening at 40. That's the current expert recommendations. And it doesn't mean that they have to go get the bone density scan. But at 40, we put their information into a calculator that calculates their risk of a future fracture. At 50 is when it's recommended that we start bone density scanning people to make sure that if they accidentally fall, they don't have a very serious fracture associated with it. And then again, let's deprescribe things that might make people a little sleepy and confused, so that they don't have that additional risk of falling. So frailty in HIV is unfortunately more common at younger ages than in people who do not have HIV. It really describes this general syndrome of physical decline. You'll hear the geriatricians say, oh, when I see it, I know it. I can recognize frailty when I just look at someone. And I think you all, if you're imagining what frailty looks like, I think you all can also kind of imagine and picture what does frailty look like. But really, it's a combination of weight loss, unexpected, not planned, exhaustion, low physical activity, weakness, and a pretty slow walking speed. So that's the general definition of frailty. It's associated with a lot of negative outcomes. But it's also, at least in HIV, associated with medical comorbidities. So here we see the little red line here on all of these different slides is the frailty. And so we see that the more comorbidities you have, the more likely you are to experience this. But there is hope in this. So some of you might be like, oh, what a bummer. Frailty is more common in HIV. It's happening at earlier ages. But there is maybe a little bit of a silver lining. So traditionally, when geriatricians talk about frailty, to them, frailty is not really a reversible syndrome. Meaning, if someone is frail, you just try to protect them, but there's not really much more that you can do to help them become unfrail. But that is not probably going to be the case for people with HIV. So there is growing data that suggests that frailty, at least in the context of HIV, may actually be reversible for some people. Thinking that people are presenting at a younger age. So the fact that people with HIV are younger when they have frailty, we still may be able to help them get out of it. So there is some benefit to being with HIV, I guess, at least in this context. Other things that can help reverse frailty include, stop smoking, lose weight, participate in exercise, some common themes here, And then, of course, there are other things that are a little bit more difficult to affect, which is like, so people who have a higher education and who are employed are more likely to be able to experience frailty reversal than not. That really speaks more to differences in social economic status than anything else. But that also, as researchers, I think we really should think about, if there is so much inequity, in our country and in our world, what type of research can we do to kind of close that gap? If we're seeing that, education and employment is associated with a positive outcome, how do we change that? And how do we make it so that that is not, it's not just privilege that, is why some people have better outcomes than others? Okay, so we're going to do, I know it's after lunch, so I have some physical activities for us to do together to kind of wake people up. So how do we assess physical function? There's really two general ways affect what you're able to do. So instrumental activities of daily living and activities of daily living. Is everybody pretty familiar with those concepts? Yes? Okay, yeah. But the other thing that we can do is we can actually do physical tests to help us understand whether or not, our patients or our clients are experiencing difficulties with physical function. So the CDC has this great website called The Steady, Stopping Elderly Accidents, Deaths, or Injuries. And they have all this free stuff that you can access there. So here are 3 of the assessments that they offer. We're going to do 2 of them. The third one basically would require you to stand up from your chair, walk 10 feet, and walk back and sit back down. And I have to time that, and we don't have enough time to do that for everybody. So we'll just do the first and the second. So the first test we're going to do is the 4-stage balance test. And everybody, please get up out of your chair. So we are going to do 4 different positions, and I'll come stand right up here so you can see my feet a little bit better. And we're going to hold each position for 10 seconds. Everybody ready? If you have some difficulty, just keep a chair by so you can hang on to it just in case. I don't want anybody falling. Okay, everybody ready? Yeah? Okay. So first we're going to stand with our feet right next to each other. Okay? If you can. Okay. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Excellent. Now we're going to go on to phase 2. You guys ready for phase 2? Okay, so this one, we're going to put your foot halfway in front of the other, like this. You get it? Yeah. So like your heel is kind of touching the middle foot of the other side. Okay, you ready? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, excellent. Okay, the third one. So this third one is associated with increased risk of fall. So hopefully everybody can get this third one too. This we're going to do completely tandem. So you put one of your foots right in front of the other one. Okay? And I've got 4-inch heels on, so everybody can do this. Okay, you ready?
I can only do it in heels.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yay! Nobody's at risk for falling. And so we're gonna do one more. Okay, you ready? One more to go. Okay, stand on one foot. You can choose whichever you want. Okay, you ready? Okay, go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Great. Fantastic, everybody. Okay. So we have one more test. Okay, so everybody can stay in their chairs but spread out a little and kind of get away from the table. Okay? So here we're going to do the chair stand. And I want you to do as many chair stands, so going from sitting to standing to back to sitting, as you can in 30 seconds. Please count your own, okay? Are you ready? Ready? Okay, go. Okay. Did anybody keep track? So here's the scale. You don't have to tell me your age or how many you did, but here's the scale. Hopefully everybody made it over the recommended number of chair stands in that period of time. Okay, thank you so much for your participation. Okay, so one of the things I think that is also really helpful, and you don't have to be, again, you don't have to be a physician or an allied provider to do this, is an exercise prescription. So I used to just tell my patients to exercise and tell them, I want you to do, like 120 minutes a week, 2 days a week, do some, some sort of weightlifting type something. And sometimes they would do it, which always shocked me, because I never really expected anybody to actually listen to me telling them to exercise. But oftentimes they did not. And if you think about it, when we prescribe a medication, we don't say things like, oh, I want you to just take some sort of medicine for diabetes, right? We're very specific, and we give a dose. Like we say, I want you to take metformin, 500 milligrams twice a day. So this exercise prescription I really like because it is specific. It tells, you can tell, like your client or your patient exactly what you recommend for them. And it's also, it gives us the ability to ramp up. So for example, I might start somebody on a blood pressure medication, they come and see me in 3 months, their blood pressure's not controlled, I'm gonna increase their dose. And this exercise prescription also enables that. So it's a nice way to encourage them to continue to work a little bit harder once they've kind of achieved some of the goals that you've originally set out for them. So the third M is medications. And so how many of you take any medication for anything? Okay. How many of you take two different pills? How many of you take 5? How many take more than 5? Okay, yeah. So there's, it's a lot, right? The medications that we can be taking for our different health conditions are a lot. But as we get older, all of us, our body changes, and sometimes there are changes that occur in the way that our body absorbs medicine. Sometimes there are changes that occur in the way that our body metabolizes the medicine. And sometimes it changes how the body distributes the medicine throughout. So over time, there are some medicines that are not as safe, or the risk of taking a medication starts to increase as we get older versus the benefit of taking the medication. But your physicians, have this medication list like this, and they have 30 minutes, and they may not have the time every visit you have to go over and make sure, are all these medications still appropriate? And, I think people with HIV are like, well, my doctor told me I have to take my medicines all the time, at least in the context of HIV. They're like, well, I got to take all these medicines all the time because they're prescribed for me. But that may not always be the case. So I think having a different approach where you're only prescribing what's necessary, regularly trying to take the time to de-prescribe medications for things, like there might have been something that was started like an inhaler, for example, got started after someone had a bronchitis. And then for whatever reason, the pharmacy just kept sending in for a refill. So the provider forgot that that's why the reason was for a bronchitis, and keeps filling it and filling it and filling it. The patient keeps getting it, so they keep taking it. But maybe they don't need that anymore. I think it's important to also educate about potential harms, and that's really hard for like infectious disease doctors and HIV doctors to do, because we want our people to take the medicines that we're prescribing, their antibiotics and their HIV meds. But I do think we do need to start thinking about it in a little bit of a different way. It's always important to see if there are a non-pharmacologic approach to symptoms. Let's try to do that first. So I think a classic example, I have a bunch of folks that have chronic insomnia. They can't sleep. And we've tried everything. And then, I don't know if any of you experienced, but some of these medicines have really bad side effects, including sleepwalking. I've had one of my poor patients ended up walking, like naked into his lobby because he was on one of these medicines and got hospitalized and then was fine the next day because the medicine wore off. But really thinking about, like what other things can we recommend besides a pill? And at least for insomnia, cognitive behavioral therapy is great for that. It's probably the best thing for someone that has chronic insomnia. And I think going beyond just the medication. And then identifying and stopping prescription cascade, which I'm going to share with you all about in a couple of slides. So polypharmacy is in 5 more. And in the US, a lot of people with HIV are experiencing polypharmacy. And the reason why this is a problem is it's not necessarily that they don't need to take all their medicines, but there are potential issues with drug interactions between medications. Once you're on so many, it's sometimes hard to keep track of. There are also some medications that should not be used in older adults, so this inappropriate medication use. And there are drug-disease interactions as well. So there are some tools that have been made in Europe and in the US. So the US tool to kind of identify which prescriptions are no longer appropriate for older adults is called the Beers criteria. It's named after a person named Beers. It has nothing to do with alcohol. And the other type of criteria is called stop and start. And these basically work in tandem with each other, the stop-start criteria. This one study done in people with HIV that are 65 years and older demonstrated that 88% of people with HIV 65 years and older had some sort of prescription issue. So this is a really, really common thing. And just to give you a glimpse of what these kind of prescribing guidelines show, on the left-hand side is the Beers criteria. So you see a condition or a topic, genitourinary. It gives you a medication, and it talks about why this medication should not really be used in older adults. On the right-hand side, you see stop and start. And it's very similar, but stop really identifies a bunch of classes of medications that are potentially harmful. So there's a lot more in stop and start than there is in Beers criteria. The start part is a lot more similar to Beers, but stop is slightly different. So I want to go through a prescription cascade. Has anyone heard of this concept before? Prescription cascades? Yes? No? Okay. So here's an example. 64-year-old male presents to clinic. He's got HIV, high blood pressure, he's got chronic pain on opioids, and seasonal allergies. He has a new sexual partner, and he's like, I'm kind of interested in a trial of sildenafil, also known as Viagra. He's like, can we try it? HIV provider says, sure. I want you to have a healthy sex life. You're undetectable. Let's go for it. 7 months later, he presents to urgent care because he's like, man, I've had these severe one-sided headaches for months now, and I've taken Tylenol and ibuprofen. Nothing really is touching this. And the urgent care provider elicits a history of family members having headaches. So she puts him on a migraine medication called sumatriptan. Then he comes back to clinic 4 months later for a follow-up visit, and he's like, man, I've got all these pins and needles. I don't know what's happening. My feet are just so uncomfortable now. So he started on gabapentin. So really what's happening here is that Viagra contributed to having the headaches. The headaches, with the sumatriptan, then contributed to the neuropathy. And now this person is getting medication after medication because of medication side effects. So this is not easy to identify, especially because people go to different doctors all the time. But as clients and people with HIV, I think it's important to understand, maybe this side effect is due to my medication and not something new that's just happening to me. Oh, wait, sorry, I forgot this one. And then he falls after getting the gabapentin, and because he's confused. Okay, so one more practice. I'd like you to share with your table. If you're isolated on a table, go join another table just for this exercise, please. Please share amongst your table one of these two things. What matters most to you and what brings you joy? Okay, go. Okay, we're gonna bring it back. I'm sorry if not everybody got to share. Okay, so the fourth M is matters most. And I think this is one of the reasons I think I really fell in love with geriatrics. And to be fair, infectious disease doctors and geriatricians, I feel like we approach our patients really similarly. But really having an understanding as a provider of what someone's personal health goals and care preferences are. But it's not just advanced care planning. So matters most can also help in figuring out how do we prioritize, which one of these screening tests, specifically cancer screening tests that we're doing, every year, every quarter, et cetera. And it enables us to have better risk-benefit discussions. So I also have this additional tool called ePrognosis. This is actually developed out of UCSF. I really like this tool, particularly for their cancer screening, because it gives a nice picture of whether or not someone, based on their comorbidities, would benefit from having to go get another colonoscopy, or would benefit from having to get a mammogram. And it's nice because some people, if it looks like there's a significant benefit and people don't want to do it, you can be like, hey, I think we should still do this. But if people are kind of on the fence, it's a nice way to be like, okay, we can not do this anymore. Okay, so I'm going to skip a couple slides about successful aging. Sorry, that's a little bit of another talk. Bring me back if you want to hear about that. And then we're going to end with multi-complexity. So multi-complexity is basically person-centered care. Really encompassing and taking into context the whole person, what they want, what's important to them, and then making decisions together about their health care. So I put this up. So if we followed all of the guidelines, this is what we would be doing as health providers. Actually, it's not, because there's another page that couldn't fit on the slide. So these are the things, that our healthcare systems and all of our guidelines and preventive therapy forces and whatnot tell us we need to be doing. But it's not possible. So really thinking about it, around what really matters most? What matters most to me? What am I as a provider most concerned about with the person in front of me? And what matters most to them? And making these decisions together. I mean, I can't tell you how many times I've ordered tests that my patients didn't want to do. So what happens? They don't do it. Because they don't want to do it. So instead of, making them feel guilty or whatever, we just have that conversation, and move forward. But it also encompasses looking at the other parts of life. So are they safe in their home? We talked a little bit about, elder violence before. What's their housing situation like? Do they have social support? What's their access to food and transportation? And how are they coping with everything that's going on? So I'm going to skip this, I'm sorry. As I've been talking through the 5 M's, I think you've heard a couple of common things that have come up that are kind of across the M's. So exercise. Exercise is good for all of the M's. Deep prescription is good for all of the M's. Substance use, not using it, but decreasing or stopping substance use is good for all the M's. Social connection and decreasing your stress levels as well. So these are the things, that having a more broad, focused look on what's going on with the person in front of you can really help you identify what can we do for this person that will give us the most bang for our buck. And these really are easy ways to start. Okay, so I think I'm done. So we do this in our Medicare annual wellness visit. It's honestly the easiest way to kind of get it done, because we have an hour to do that. But there are other models of care. I wasn't going to talk about that anyway. So I will stop and leave room for questions.
Thank you, Dr. Karris.